Topic of my study was a study of hypercoagulable and inflammatory markers in COVID-19 patients. This study we did in the Department of Biochemistry at Government Medical College, Amritsar. So next slide, please. So we all know that hemostasis is a normal physiological process. And the endothelial cells, they act as an anti-thrombotic previous slide, please. Anti-thrombotic barrier comprising several components such as negatively whereas subendothelial layer is a reservoir of thrombogenic proteins such as collagen, von Willebrand factor, and thrombosportin. Hence, always there exists a delicate balance between the thrombogenic and anti-thrombogenic factors, and this balance is very important so that a normal hemostasis and a coagulation is maintained. Next slide, please. So we all know that SARS-CoV-2 was responsible for the COVID-19 pandemic. So what did this virus uh, does to this balance? So basically this virus, it promotes the release of the inflammatory cytokines and causes the hyperactivation of the platelets, causes its aggregation, leading to increased molecules which can promote inflammation and hypercoagulation. So a complete cascade, it works in combination, and that put an individual to the risk of morbidity and mortality. Next slide, please. So with this background, that there is always a fear of hypercoagulation and inflammation associated with this virus. So we wanted to investigate the coagulation and inflammatory status in COVID-19 patients, because I would like to mention over here that this study we did when the knowledge was still growing regarding this virus. Now in 2023, there are extensive studies and reports which has put light on the mechanism behind the cascade of inflammation and hypercoagulation. But when this pandemic was actually erupting, we didn't know much about it. So at our place, when because the college was associated with a tertiary care hospital, so many patients indoor and in ICUs and on OPDs, they were coming with one problem or the other. So we were really wanted to see that if this coagulation and inflammation, it actually do exist in these patients, or is has some connection with the pathology which is responsible for this huge mortality and morbidity. Next slide, please. So this study was conducted in the clinical biochemistry laboratory at the biochemistry department at Government Medical College, Amritsar, Punjab, India. So total of 500 samples of COVID-19 patients either admitted or they were attending OPDs were analyzed for plasma D-dimer, procalcitonin, interleukin-6 and C-reactive protein. This study was conducted in the year 2021 when knowledge was still growing regarding SARS-CoV-2. So no exclusion criteria was followed just to avoid bias, because we were like interested to know the status of these parameters irrespective of any allied conditions like diabetes or anything else. So we didn't follow an exclusion criteria at that point. So plasma D-dimer, procalcitonin and interleukin-6 were estimated adopting the chemiluminescence immunoassay. The material was procured from Maglumi Snipe. The samples were allowed to run after checking for controls. Serum C-reactive protein was estimated with quantitative CRP turbidimetric method, procuring kit from BioLine Diagnostics. Now these cases were referred to us to the biochemistry laboratory. by the concerned physician after following the study protocol and institutional ethics. So we were unable to include any healthy controls as during that period, every second or third person was either infected or was not willing to visit the hospital. So the values were compared with the reference values which were given in the inserts which came along with these kits. Next slide, please. Now, as far as the observations were concerned, now COVID-19 has extended the list of investigations in the laboratory, and the knowledge is still growing to combat this deadly disease. Next slide, please. So this was the whole, the picture. So basically, this table shows the dysfunctional and coagulation and inflammatory system prevailing in COVID-19 patients. So we have these parameters: D-dimer, C-reactive protein, procalcitonin, interleukin 6, and LDH. Now, see, RV stands for the reference value, which was given in the insert. So now you can very well see that all the values, if the D-dimer in microgram per ml, the reference value should be less than 0.5. So we were having a mean of 20. Similarly, C-reactive protein, if the reference was less than 6 or the desired value, we were having a mean of 84.5, which was quite high. And regarding procalcitonin, it was less than 0.05 nanograms per ml, and we got 1.62. Similarly, interleukin 6, it should be less than 7, and we got 115. And similarly, LDH, the range was 225 to 450, and we got 1967. So see, all the parameters, D-dimer, C-reactive protein, procalcitonin, interleukin 6, and LDH, they were all deranged uniformly in all these patients. Next slide, please. So D-dimer, CRP, interleukin 6, procalcitonin, and LDH levels were markedly raised in COVID-19 patients as compared to the reference levels mentioned in the insert, as I have this showed you in table 1. So this is a clear indication of dysfunctional coagulation and inflammatory system prevailing in these patients. Next slide, please. Now, in order to have a clearer picture, the patients were segregated on the basis of selected ranges of the parameters. So we wanted to see if there is any overlap or something like that. So which or some miscalculations were there or certain overlapping was there. So we wanted to have a very clear picture that exactly what is the actual status. So we have divided uh, the D-dimer levels into 3 ranges. So less than 0.5, then 0.6 to 1, and then more than 1. So see, majority of the COVID-19 patients, they were having a values of more than 1. And even I have seen that some patients showed up to level 40 microgram per ml. So you can see that, without a very considerable overlapping or considerable this decline, all of the patients, if we would have taken like more than 500 or like 1000 or 2000 depending upon the number of the patients visiting at that time the hospitals, so this number could be more. So but clearly majority of our cases which we observed and which we analyzed, the D-dimer levels were quite high. Next slide, please. So similarly, we also segregated the C-reactive protein levels. So into less than 1, then 1 to 6 milligram per liter, and then more than 6. You see, higher C-reactive protein predominates in majority of the COVID-19 patients, and they were having levels more than 6 milligram per liter. So it's an acute phase protein. We all know that the levels, they are raised in response to inflammation, no doubt it's a non-specific, but at that time we were dealing with the this COVID-19 patients. So undoubtedly, this was quite related to that uh, pathology. Next slide, please. Now, see, uh, the same status we observed in interleukin 6 levels. Now, interleukin 6 levels, you can see a very yellow, I mean, this very, this less number of patients, they were having levels less than 7, depending upon individual immune response, but majority of the patients, so they were having values of more than 7. So only 12 out of 500 patients, they were having levels less than 7, and all other patients, they were having levels more than 7 picograms per ml. Next slide, please. Now again, there was predominance of increased procalcitonin levels in majority of the COVID-19 patients. You see that majority of the COVID-19 patients, they were having levels of more than 0.05 nanograms per ml. So this relevant increase was specially observed in ICU cases and those admitted in wards. These patients had significantly raised procalcitonin levels as compared to those who were only visiting outdoors and were advised home isolation depending upon their clinical condition. Now, the I mean, what does this additional parameter uh, shows, or what this increase indicates? So high PCT levels indicate the bacterial infection in a due course due to inflammation giving way to normal bacteria, especially to the lungs. So if we want to frame a strategy or to start an antibiotic therapy, then certainly, because antibiotic therapies these days not recommended if the patient is asymptomatic, or this is advised home isolation. But the deciding factor is the procalcitonin levels. So if you advise the procalcitonin levels, get these levels checked, and you see if the levels are coming more than 0.05 and the patient is symptomatic, then certainly it is the, I mean, the time to start the antibiotic therapy, because along with other pathology, the bacterial infection, it has also taken place. So the most, I mean, advanced stages comprising the bacterial infection, they can be treated, or the treatment strategy can be framed basically depending upon the procalcitonin levels. And this I mean, in a real time picture at that time we observed, and because we were in constant touch with the clinicians, and we were like, because we wanted to try to correlate the findings with the clinical situation of the patient. So the coordination was awesome, and accordingly, depending upon the levels of the procalcitonin and the symptoms of the patients, they were being given the treatment. Next slide, please. So again, we also found an increased LDH activity in majority of the COVID-19 patients. So majority of the patients, they fall in the range of levels more than 800 international units per liter. So only 40 COVID-19 patients had their levels below 800. Rest 460 had LDH levels more than uh, 800 international units per liter, with a mean of 1967. So none of the patients fell in a range of 225 to 450, which was given in the insert. Next slide, please. So we were in a constant touch with the clinician regarding the condition of these patients, especially those in ICU as well as admitted in the wards. All the parameters, I mean, except LDH levels and especially procalcitonin levels, were highly correlated with the severity of the disease. The investigations were repeated at intervals as referred by the clinician for treatment strategies, and the outcome really improved as levels declined. Next slide, please. So how this cascade actually works. So the inciting event stimulating the vicious cycle of inflammation and thrombosis actually starts in the pulmonary alveoli by the entry of SARS-CoV-2 through the ACE2 receptors. Now what happens? COVID-19 infection starts inflammation process in alveoli through ACE2, and there is a cytokine storm. Consequently, there is a surge in interleukin 1, 6, 8, and tumor necrosis factor alpha. We only studied a surge in interleukin 1. No, undoubtedly, interleukin 6, 8, or TNF alpha could have also been increased. Now, there is infection of endothelial cells causing its activation and dysfunction, resulting in platelet activation and promotion of thrombogenic environment causing fibrin clot formation. Now, it is because of this there is an increase in D-dimer or platelet activating factors. Now, I have included this very interesting point that it would be interesting to see if it also causes activation of ASK1 in platelets. This I put this point because when I was doing postdoc, so we were studying the activation of this apoptosis signal regulating kinase 1, which is a MAP3 kinase, and this kinase is present in human platelets. So we used different kind of this stimulators like thrombin and oxidized LDL, which was able to stimulate this ASK1. And when this platelets get stimulated, so naturally there was a degranulation and the platelet aggregation, because we also did the platelet aggregation studies. So it would be interesting to see if this virus also by some mechanism causes the activation of these MAP kinase in platelets, and shifting all the delicate balance between hemostasis and coagulation towards hypercoagulation and inflammation. So at some point of time, we will see if we can do this study, um, hopefully. But unfortunately for these, we need the COVID-19 patients, and I really wish that this pandemic would never come back. So anyways, so this PCT levels, that is procalcitonin levels, also increase significantly under the effect of cytokine storm, because it is released by all parenchymal tissue in this state. So there is a very, a positive association between the hypercoagulable state and inflammation. And undoubtedly, all these parameters which we studied, because at that point of time in 2020 to 21, the 1 year period of study, which when the knowledge was still growing and we were not sorry, we were not sure that if all the patients they would show these similar results without any significant overlapping. And yes, we actually saw that there was a clear cut increase in all these parameters. And if we want to follow up the patient and frame the treatment strategies, so we had to investigate all these parameters so that active treatment can be framed. Next slide, please. So I would not say that's a conclusion. I would say it's just an inference. So the hypercoagulable state and inflammatory cascade in COVID-19 has emerged as a major pathological occurrence. The worst part is that this dysfunction is more serious in COVID-19 patients, responsible for increased illness and mortality, because the pace is so high, and the spread is so fast that depending upon the individual's immune response, we always see the consequences accordingly. So thromboinflammation process starts in pulmonary vasculature and then adopts a general course of infection affecting major organs. Reliable and quick results of these parameters can really help the clinician to frame treatment modalities, because our experience shows that every human body follows a different baseline response to this infection, depending upon their integrity of the immune system. A clear-cut increase in D-dimer, interleukin 6, CRP, PCT, and LDH in COVID-19 patients is suggestive of hypercoagulable and inflammatory state, irrespective of other comorbidities or other features. Next slide, please. So this was the study. I mean, this was a very basic study, but at that time it was not that basic, because uh, the load of the patients and who were referred to our laboratory for investigations, and the burden on the clinician was too much, being at working at the tertiary care hospital, that at that time our focus was only on the results of these parameters and how they well correlated with the clinical stage of the patient. So certainly the the timely results and the this positive interaction and communication with the clinicians certainly helped many patients at that time, so that they can move out of the hospitals, uh, I mean without any significant illness or morbidity. But certainly deaths also followed, which we couldn't do much at that time. So thank you so much. So I'll be happy to answer any questions.